آه، اوكي.
طيب, as I promised you, we're gonna start on the echo block. And this is just introduction to echocardiography. But you know that we have two positions for echocardiography, this one and this one. Okay. So supine and left lateral. طيب, in the left lateral, we get the parasternal, which is here, the apical, which is here. And from this position, we get the subcostal, which is here, and suprasternal, which is here. So we have 4 windows, or you can say 5 windows, which the fifth one is the right parasternal. Like in this is used for special circumstances, like when we are looking for aortic stenosis and high gradient and we use a different probe. Like in the conventional windows are 4, okay? So I encourage you to stop me anytime you have any questions. Don't keep the question to the end of the presentation, okay? So we have here is the parasternal long axis. Here is the apical window. Here is subcostal, and here is suprasternal. These are the 4 windows we use. So I'm positioning the patient is so important لأنه it has an impact on the image quality. So the right way of positioning the patient is important for the image quality on one side and is important for you as an operator on the other side. لأنه أنت you need to be comfortable. So being comfortable depends on positioning the patient, you know. يعني إذا البيشنت في position زي ده, you are on here and you want to come all the way here, it's going to be difficult. It's not like this one. So make sure that you are comfortable and the patient is comfortable and the image quality is at best in terms of positioning the patient. So the patient should be positioned this way and his left arm should be folded below his head in this way. Some people say it's better to be outstretched. لأنه أنت want to open the ribs, okay, and improve the image quality. Good. The very first view you get is the parasternal long axis, which is this one, okay, in which you are gonna see the left atrium, the mitral valve, the LV, the aortic valve, and the RV, okay? طبعا it's important we know that we can change the depth. Depth. What's the meaning of depth? In the echo machine, there is a button in which depth is there. So you can change the depth, increasing the depth and decreasing the depth, okay? If you increase the depth, you are gonna see more of around the heart, yeah? So if you are looking for like pleural effusion and something extra cardiac, you need to increase the depth, okay? Any questions so far?
No.
Great. Now we cut the heart when you have 2D echo. It's basically about what? We don't have the entire heart in one image. So we are cutting different slices of the heart in different orientation. So you do mental summation of these images to have the comprehensive holistic picture of the heart. So at any particular image, you don't have the entirety of the heart in front of you. You are seeing just a slice of the heart, one slice of the heart. And you have to know where you are, what structure are there in this particular orientation or slice. So when we cut in the short axis, we have 3 levels of the short axis. These are the short axis. We have the short axis at basal level aortic valve. You see the aortic valve in the middle, pulmonary valve on the right, tricuspid on the left. And we cut at the basal level in which you see the mitral valve. Then we go to the mid cavity, and this is marked by the two papillary muscle. This one is the anterolateral, and this is the posteromedial. Okay? Why? Because here is anterior portion, and this one is the posterior portion. So this is going to be anterolateral, and this is posteromedial papillary muscle. Okay? So this is the short axis. And here in the short axis, you see this one at basal level because I'm seeing the mitral valve. And I will see also part of the RV here. Here at mid-cavitary level or papillary muscle level, in which you see the anterolateral and posteromedial papillary muscle. And this is at the very basal level in which you see the aorta in the middle, the RVOT on the right, tricuspid on the left. Okay. Now we come to the apical window. In the apical window, you see the most pleasant picture, which is the apical four, the apical four. And the conventional format is the LV on the right side, the RV on the LV on the left side, the RV on the right side. طبعا Mayo format is the opposite, but the standard format we adopt and in Sudan is this one, LV on the right, on the left side. So we have LA, mitral valve, LV, RA, tricuspid valve, RV. And then from the same apical window, in the same position, without moving the probe anywhere, we just do tilting of the probe towards the patient's head. We get the apical 5 because we open the aorta. And this is important view because in which I can interrogate the flow across the aortic valve in case I have valvular obstruction, aortic stenosis, and all of that. Yeah. And I can tilt in the opposite direction to go posteriorly. Here, I am opening anterior structure, which is the aortic valve. If I want to open the posterior structure with the coronary sinus, I go in the opposite, I tilt in the opposite direction, okay? And I get the coronary sinus. Sometimes you need to look at the coronary sinus in cases of congenital anomalies, in cases of persistent left SVC, dilated coronary sinus for fistula formation, stuff like that. And then from the same apical window, I change the orientation to get the apical 2 chamber, left atrium, and left ventricle. And a different orientation, I get the apical 3 chamber, left atrium, left ventricle, and aorta. Yeah. So from the apical window, now what we get from the apical window, 3 chamber, 5 chamber, 2 chamber, and 3 chamber. Okay. Then we come to the subcostal. In the subcostal, you get this view, okay, in which the RV is hugging the liver. You see part of the liver. And this is kind of apical 4 chamber. It's kind of 4 chamber view obtained from the subcostal window. You can also tilt the probe clockwise 90 degrees to get the IVC. And this is important. The IVC is very important because by which we assess the central venous pressure. We assess the central venous pressure by this one. And sometimes it guides the fluid management. That's why the intensivists are so interested in getting the IVC, and they hold their probe frequently to check on the IVC and the state of IVC to determine if the patient is fluid deficit or eovolemic or not. Okay, so this is the IVC from the subhost. And here you look at the IVC in different patient. If you look here, this IVC, compare it to this IVC. This is the liver, and this IVC converges with the hepatic vein. Here I don't see the hepatic vein. Okay, probably is not well seen, but because it's not as dilated as in here. And even if you look at the IVC, it looks so dilated compared to this one. Another feature is not collapsible, so it's fixed in size. It doesn't change like in this one, it changes with respiration. So the evaluation of the IVC is done under two terms, collapsibility and size. And depending on these two metrics, you determine the central venous pressure, okay? So, for example, if it is less than 1.5 centimeter and more than 50% collapsibility during inspiration, the SVC is between 0 to 5. If it is more than 2.5 centimeter and non-collapsible or collapsibility is less than 50% during inspiration, it is like 20, SVC is approximately 20 millimeter mercury. Okay. So far, so good, Shabab?
Yes, very nice.
Yeah.
Boss Hatim, if you allow to me just one
Sure.
question, I have some confusion regarding the IVC compressibility and size. For
Mm.
example, if it is dilated and not compressible, so what do you mean for me?
Yeah. Dilated means here, let's assume that your patient is 2.5 centimeter. Okay.
Yeah, yeah,
Now, then we look at the collapsibility. There is collapsibility or there is no collapsibility. And if there is
yeah.
collapsibility, is it more than 50% collapsible or less than 50% collapsible? So if it is dilated IVC with no collapsibility or less than 50% collapsibility, the central venous pressure is as high as 20.
Mhm.
Okay.
Thank you
طبعا
so much.
عشان to determine the collapsibility, because collapsibility is what is respirophasic, is not beat to
Mm,
beat, is respirophasic. That's why you have to obtain a longer image, okay? Longer image
mm,
is spanning at least 6, better 10 beats, okay? تمام؟
mm,
10 beats
okay.
عشان انت تقدر to assess for collapsibility. Otherwise إذا انت بس you just put your probe here 1 2 beats وقلت ما في collapsible، ممكن يكون collapsible at the 5th beat بس انت ما انتظرت enough. You have to wait لأنه is
Mhm,
respirophasic. Remember إنه respiratory rate الريشيو بينه وبين الهارت ريت is like 1 to 4 1 to 6. معناته انت محتاج 6 الى 10 to capture 2 respiratory cycle. فبالتالي لازم تكون شويه aware ولازم تكون cautious when you are trying to spot any respirophasic excursion. And this applies to tamponade, applies to constrictive pericarditis, applies to
mm.
IVC assessment. Remember انه الاشياء دي كلها respirophasic, so you have to have longer imaging عشان انت you get them right. If I
Thank
look
you
at
so much.
this parasternal long axis and I want you just to roughly give me an idea about how you think if I tell you that this one here on the right, this one is normal function. So I'm assuming that the ejection fraction here is 55, 60%. Okay, so what do you think about this patient here? This one.
Dr. Hatim, for the other people, I don't know, but for me, the playing is very delayed, only
Ah,
moving very slowly.
really?
very slowly moving يعني.
بالله. طيب شباب الايمجز slow moving for all of
والله
you.
لا شايفينها كويس والله.
مم.
مشكلة عندي أنا معنا هنا.
Yeah. طبعا I want to remind you something when we come to evaluate the LV and RV function. The evaluation of LV and RV are different. When we come to the LV, if you look at this part, you might say that the ejection fraction is normal. But that wouldn't be accurate unless and until you see the entirety of the heart. You see the 17 segments, which are not all included in this image, okay? Because the LV dysfunction might be regional and it might be global. If it's global, this image is gonna reflect the entirety of the heart because what is seen in here is gonna be seen in the rest of the segments. But if it's global, you might have contractility well in here and well in here, but the apex is aneurysmal, for example, okay? So you miss the actual or the accurate assessment. Remember the regionality of the LV function. يعني because of ischemic cardiomyopathy, you might have heterogeneous or kind of different regions with different contractility and stuff like that. So there is no way you assess the LV function unless you analyze the entire 17 segments. While in the RV is usually and almost in the vast majority of cases, when the RV gets weak, it gets weak globally, okay? So any point in the RV is gonna represent the entirety of the RV. So we don't have this problem of regionality in the RV as we have it in the LV, okay? But بعدين حنتكلم لما نتكلم عن chamber quantification LV-RV, we are gonna discuss on that. طيب, back to this one. We said that this is approximately normal ejection fraction. If we look at this one, this is hyperdynamic. Yani look at these walls are approximately touching. Yeah, so this is hyperdynamic or hypercontractile. And this is important, by the way, لأنه ejection fraction range حقه في heart failure with reduced ejection fraction, في heart failure with normal ejection fraction or with preserved ejection fraction, وفي heart failure with super normal ejection fraction. يعني الآن the more you go north in ejection fraction, things are not good, by the way. يعني انت when you get an ejection fraction of 70, 80, 90, that's not good news. ولذلك بقت important انه الhyperdynamic heart is not as good as it's thought to be. Yeah, you have to have a relaxed heart with ejection fraction of 55, and there is always a cavity. Obliteration of this cavity due to hyperdynamic and hypercontractility is not good. Okay, so this is hyperdynamic, this is normal. Now, if you look at this one here, it is abnormal. Yeah, now how much is abnormal? It's like mild to moderate. And this one here is also abnormal. It's dilated with weak contractility. This is severe LV dysfunction, severe LV systolic dysfunction with a small rim of precardial effusion, as you see here posteriorly and probably anteriorly as well. This is just, I brought these images to give you an idea about how you could evaluate the contractility visibly. Yeah, طبعا the visual assessment of contractility, the so-called eyeballing, yeah, eyeballing. That's eyeballing I don't actually recommend, and we have to go for لأنه فيه subjective factor. It needs experience, you know. Usually we better go by objective ways of assessing the LV function, like more like biplane, Simpson methods, and stuff like that. It's always better to be more objective than subjective. لكن ناس كثيرين جدا because of their experience, they just do this eyeballing and they strike the right ejection fraction because of their experience, you know. So they know exactly this is the normal, this is hyperdynamic, this is like 35, 40 ejection fraction, this is 20% ejection fraction, yeah, by eyeballing. If I look here, this is apical 4 and parasternal short axis. In this apical 4, the most striking feature is the dilated right side. Dilated right side. طبعا the image quality isn't so perfect. وطبعا you have to expect انه echogenicity is different in different patients because of subjective factors. لكن في objective factors of echogenicity انه انت السيتنج ما عندك كويس، positioning of the patient is not good. ففي patient related factor، في operator related factor، في machine related factors. فتry to make sure انه at least your duty of improving the image quality is done right. انه انت you position the patient right, you put the setting at the best optimal setting for this particular patient. بعدين مرات في patients كده inherently are poorly echogenic. No matter how hard you work on the image quality to improve it, دائما بيكونوا كده. Okay? وفي situations of emergency، يعني مرات انت البيشنت ما بيكون حتى قادر to tilt himself or herself to the left side because of severe chest pain, severe shortness of breath. We have done echoes in a patient semi-sitting, yeah, because they cannot lie flat. Yeah, like in this comes at the cost of the image quality. So we have to accept. And this patient in particular was a patient of pulmonary embolism. That's why he was seriously sick, and that the image quality was depressed because of that. So we see the RV is dilated, and we see a mass here. So a thrombus is looping into the right atrium. And you look here at the D, this is called the D sign, when the LV is compressed due to RV dilatation. Yeah, flat septum, D-shaped LV because of dilated RV. And if you focus more in here, you are gonna see that this wall of the RV is hypokinetic, while the apex is preserved contractility or hyperdynamic. So this has a name, this sign has a name, which is specific for pulmonary embolism. Anybody knows this name?
Yes, McConnell sign.
Yes, exactly. McConnell sign. So this sign is specific for pulmonary embolism, in which you have RV free wall hypokinesis, but apical hyperkinesis. Yes, okay. Or you could say apically sparing RV hypokinesis. Apically sparing RV hypokinesis. This is the McConnell sign, which is specific of pulmonary embolism. Now, when we have precardial effusion and pleural effusion, sometimes we get stuck about which is which, and we take our landmark at the descending aorta. Here is the descending aorta. This black hole immediately below the atrioventricular junction is the descending aorta, okay? So if the fluid is medial to it, it's precardial effusion, and usually it ends abruptly here. If the effusion is lateral to it and extend wherever, this is pleural effusion. This is not easy, by the way. Sometimes we get so lost between which is which, pleural effusion or precardial effusion, especially when the patient is having too large effusion, precardial and pleural effusion. For sometimes it's not easy. That's why you have to go for accurate evaluation, you know. Look at the descending aorta and see which is which and stuff like that. But this is the landmark for distinguishing the two pools of fluid. Okay. Now look at this one here. We are seeing part of the LV in the parasternal lung axis, and we are seeing this echolucency space or echolucent space, which is what? Fluid, right? So this is precardial fluid or precardial effusion. Now look at it here. Look at this. What is this? Again, the heart in the short axis, and there is something around the heart. Is it fluid? This is fluid. This is not fluid, yeah? This is fat. Good. So sometimes the fat might just look alike to fluid. That's why you have to know how you distinguish between the two. And it's not uncommon to see fat around the heart. And in fact, there are two pools of fat pad around the heart. One is immediately overlying the heart up until the pericardium, and this is called epicardial fat, this one, this part. And the other one is this one, which is called pericardial fat. So we have two pools, epicardial fat, which is immediately overlying the heart, and pericardial fat above the parietal pericardium. Two pools of fat around the heart. Okay. ومرات لما تعملوا chest x-ray ويكون الهارت according to your estimation فيه cardiomegaly, you might get referral from primary care على إنه this chest x-ray is a cardiomegalic heart for further workup. You do echo, the heart is normal. How you explain that? Explain that because of the orientation of the chest x-ray might magnify the heart erroneously, or because of the fat. يعني chest x-ray is gonna see this, all this. Doesn't distinguish between the wall and the fat. So it appears in the chest x-ray as big, while when in echo, you are gonna evaluate, you are gonna separate the wheat from the chaff, so you're gonna see the heart proper and the fat. So you know which is which. ولذلك الchest x-ray is misleading in terms of LV size assessment for so many reasons.
So, Dr. Hatim,
اتفضل.
if there is pericardial fat, يعني if I found this, should be found epicardial fat and pericardial fat together to say this is the fat, not fusion.
Yes.
Together should be there. الاثنين
معلش
لازم يكونوا قاعدين.
Yes. لكن ما شرط يكونوا واضحين زي الوضوح دي. يعني في بعض الأحيان small bits of fat in here and here hardly seen, لكن مرات بيكونوا very large. I have seen patient refer to oncology, okay, and done PET and biopsy and lots of stuff because they have seen fat pad that are very accentuated and very robust, and they thought this is a mass around the heart. Yes. So we have to know that the heart is encased in a fat pool, okay? And this fat thickness depends on several factors. By the way, the epicardial fat in particular is associated with visceral adiposity. So as we have visceral adiposity, we can have epicardial fat. And it has the same risk problems. يعني الآن visceral adiposity relates to cardiovascular risk and to all other kind of diseases. The same applies to epicardial fat. ولذلك epicardial fat thickness is considered non-conventional risk factor for coronary artery disease. If it is thick, it indicates that this patient is more prone to cardiovascular disease. Okay. غير إنه الفات بالمناسبة الإبيكارديال fat الآن is found to be associated with diastolic dysfunction, associated with inflammatory condition that affects the presentation and manifestation of coronary artery disease. Yeah. So there are so many studies that relate epicardial fat to so many disease entities in the heart. But anyhow, epicardial fat is gaining more interest because of its association with coronary artery disease. Yes, we have done a study about epicardial fat thickness, and I think there are so many studies you are going to look at in literature about epicardial fat thickness and its association with coronary artery disease. طيب إذا أنت you see it, shall you report it? Yes, and I think you should. إذا كانت thick, you write in the summary there is thick epicardial fat pad. Okay, then it's meaningful in terms of risk categorization. But this applies to the epicardial fat thickness. If you ask me what about pericardial fat thickness, it has not found to be of the same clinical significance as epicardial fat. طيب, here we have a heart and we have large pericardial effusion around it. And as you see here, this is large pericardial effusion. Again, the image quality isn't good, but expectedly because of the patient's condition with this tamponade-like presentation or tamponade presentation, because we see that the RV is collapsing. Don't worry about the words I'm saying now about the echo, because we are going to study each one separately. Now I'm just going to do a quick sweep on echo, then we will come later in later sessions about each one in detail, okay? But here is a large pericardial effusion. And the pericardial effusion, it has to be evaluated in terms of size and its hemodynamic consequence. So how much this fluid is affecting the hemodynamics of the heart, this is important, because if you write there is large pericardial effusion, what is the clinical uptake of this message? Is weak. Yeah, large pericardial effusion. The referring clinician is stuck what to do about this patient. Yeah, but if you tell him or her that this fluid is large and it's compressing the heart, as evidenced by so and so and so and so, he's probably gonna have a decision to make, and he's gonna probably stick a needle to drain this fluid. Okay, or if you say that there is no evidence of compression, again the decision is made, or you help in decision making by these statements. So it's important you quantify the effusion and you qualify the effect of the effusion on the heart. And this is always the message in echo. In echo, we do two kind of roles. First, we have to quantify and describe the size, describe the morphology, then we quantify the effect on the heart. Yani if you have like rheumatic mitral valve, so you are gonna say this is rheumatic mitral valve. Okay, that's okay. This is morphological description of the mitral valve. Then you have to tell about the degree of stenosis and the degree of mitral regurg associated with this rheumatic mitral valve. How severe the mitral stenosis is, how severe the mitral regurg is. Not only that, even the consequences of that, the LA dilatation, the pulmonary artery systolic pressure, the status of the LV. So you have to give a complete picture about the consequences of this disease on the heart. Okay? So remember, echo، عشان كده مثلا الناس بتقول انه echo is cardiology. نعم، لانه انت you don't just يعني مثلا هي echo is a technology of ultrasound. Basically it's radiology, لكن radiologists cannot do echo at all لانه he has to be cardiologist before ما يبقى echo cardiologist. يعني مثلا السي تي cardiac CT you can be a radiologist and you can do it. CMR you can be a radiologist and you can do cardiac MRI. لكن you cannot be a radiologist and you do echo, never at all. لأنه echo needs a natural cardiologist, يعني well-versed cardiologist, لأنه he has to describe things in several dimensions, okay? فبالتالي he has to know the entire scope of cardiology. He knows each entity, how it influenced the heart, and how the management is gonna be according to the description he is gonna state in his or her report. Okay. طيب طبعا جزء أساسي من الإيكو is the Doppler. Okay. وبعدين لما نيجي نتكلم عن الدوبلر, which usually the Doppler represent, according to the fellows we teach, is the hardest part of echo for different reasons. لأنه الناس are easy with the 2D and the structure and the abnormalities, the anatomical morphologies. Like when it comes to Doppler, it has a different way of analysis which are not so well taken by them. لكن I assure you, we are going to do it so easy and you're going to know everything about it. In Doppler, we have PW and we have CW and we have color Doppler. So we have, and we have TDI. So we have 4 types or 4 modalities of Doppler. PW stands for pulse wave Doppler, like this one here, interrogating the mitral inflow. And in here, interrogating the LVOT, okay? And we also have CW, which is continuous wave Doppler, like in here, for high velocities. Here is interrogating the TR signal, okay? We also have color Doppler and TDI. TDI is like this one, tissue Doppler images. So here we are interrogating the medial annulus, and that's what we get. Here the lateral annulus, and here what we get, okay? So this is tissue Doppler images. Again, this is tissue Doppler images of the right ventricle, tissue Doppler images of the right ventricle. And this is color Doppler. Color Doppler is about flow and flow dynamics. And we have 2 colors. Conventionally, we agreed on 2 colors, which are blue and red. Okay, blue and red. So blue means what? Blue means away from the transducer. Red means towards the transducer. Okay? These are things that are agreed upon by convention. يعني ما هي, this is conventional. We just agree on that color coding. We can change it anytime we wish. But we agree on that the blue is away from transducer, red is toward the transducer. يعني بالتالي if you see blue blood, if you see blue blood means that is moving away from transducer, it's moving away from here, it's going in this direction. That's blue. If the blood moves toward the transducer, it's gonna be red. Okay, and if it is blue or red, that means it's laminar flow, laminar flow. So it's laminar flow towards the transducer is red. Laminar flow away from transducer is blue, both of which are normal. Yes, with a special exclusion. We are going to talk about it. Like in generally speaking, the laminar flow معناتها laminar flow, that the normal physiological flow is laminar. It might be towards the transducer as red or away from it as blue. طيب, what is the abnormal flow? Abnormal flow is going to be a mosaic. Meaning what? Mosaic. Mosaic is the opposite to laminar flow. Laminar flow means it's moving homogeneously with uniform velocities in one direction. Mosaic start to be turbulent flow. So the flow is going in different direction. And this is non-physiological. This is pathological flow. معناتها the flow of the blood is met by obstruction or by any abnormality that disrupt the laminarity. فبقى is moving in different direction. So whenever you see a mosaic flow, which is the mix of blue and red, معناتها you have to pause, you have to scroll slowly and see where the problem is. لأنه في الغالب the mosaic flow is pathological. Okay? يعني مثلا if I take this one here, look at this color. This is not blue and not red. Like this is not blue and it's not red. So this is mosaic color. That means there is a problem in the flow here. This is severe mitral regurgitation and also there is aortic regurgitation. But if you look in here, you see the flow is blue and red, blue and red, blue and red. So this is physiological flows. Okay. We also have M mode. And whenever you hear the word M mode, it stands for motion mode. M mode, I want you always to remember one word about M mode, which is what? Can anybody guess? Anybody can guess? Something relates to the resolution. Resolution طبعا أي image technology or imaging modality عندها resolutions, spatial resolution, contrast resolution, temporal resolution that characterize each and specific one. Okay. يعني الإيكو عندنا temporal resolution. Temporal resolution بمعنى how fast you capture moving object. يعني الآن أنت إذا عندك كاميرا لو temporal resolution بتاعتها is poor and you are trying to capture a moving object, it's gonna be hazy. لكن إذا الكاميرا حقتك temporal resolution حقها is fast, okay, you are gonna freeze the motion. الموشن is gonna be high quality. يعني التصوير حقك حيكون good quality.
Yeah,
فالtemporal
same
resolution
like the megapixel in the camera.
exactly بالضبط. So a temporal resolution define the frames in the frame rate. يعني how frequent you can image the moving object. Okay. Now for M mode, طبعا احنا في الايكو عندنا 2D، عندنا دوبلر، عندنا tissue دوبلر، عندنا 3D، عندنا strain، صح؟ في different modalities. The best temporal resolution belongs to the M mode. The best temporal resolution. The best temporal resolution M mode. Okay. ولذلك ال M mode can capture very subtle abnormalities in motion. You can't easily see it by 2D. ولذلك like when we are going to discuss بعدين specific disease entities, we are going to see the application of M mode in particular situation to show how much the M mode has the best temporal resolution in the way of capturing very subtle excursion of the walls that can't be seen by 2D. You can't see it by 2D. يعني مثلا أديك a simple way. Look at it here. Look at this mitral valve. Just a moment. Do you see this mitral valve? This is 2D. Can you describe the opening of the mitral valve? It opens and it closes, صح? That's what we see. It opens and it closes. That's all we see. It opens once and it closes once. Then it opens, then it closes. طيب, if I put M mode along the mitral valve, that's what I'm gonna see. It opens, it closes, and it opens again and then closes. So it shows me an additional motion that I couldn't appreciate visibly when I look at 2D. Yes? فبالتالي ال M mode gives us an idea about the subtle, detailed motion of the walls and valves much better than 2D. Okay? عموما ال M mode, we have standardized 5 images M mode in each and every echo routinely. طبعا في special situation dictates special kind of M mode of images, لكن routinely we have 5. one for the LV. So you cut through the LV like this. You drop your cursor here and here, what you get. And this gives us the LV diastolic dimension and LV systolic dimension, from which I can evaluate the fractional shortening. Across the mitral valve, I move the cursor a little bit towards the mitral valve to cut through it. And here what I get opening, closing, and opening again, and then closing. And it has a name actually. This is called E. This is called A. This is called C. This is called D. And this one, the slope from E downward, is called F slope. Why are these names? Because it has meaning when we come to describe the different abnormalities of the mitral valve. Okay, but what you have to remember, if you are not interested to memorize all these letters, are just two. This is E and this is A. E and A. Okay. And also we have to cut through the aortic valve. And here what we get, the box of the aortic valve, the rectangle shape of the aortic valve. And here is the closure line. This is also important. Why? Because when we have diseases of the aortic valve, like aortic stenosis, bicuspid aortic valve, aortic prolapse, it's gonna change this morphology. So this is the normal morphology. It is a rectangle and the closure line is in the middle. Now we have the one which is really important is the RVM mode. RVM mode. We go to the right side and we drop our cursor along the lateral annulus of the tricuspid valve, and here what we get, M mode. And this M mode has a name. Do you know what name is that? Yes,
TAPSE, tricuspid
TAPSE.
annulus plane exclusion.
Exactly. Very good. This is called TAPSE. TAPSE. So this stands for tricuspid annular plane, because here is the tricuspid annular plane. So what is the remainder? SE, systolic excursion, because I'm measuring the systolic height. I'm measuring the systolic height from the baseline to the systole. And this reflects the RV systolic function. And it is reproducible, reasonably accurate, and this is the standard metric for RV systolic assessment. TAPSE, okay? So this is 1, 2, 3, and 4 M mode. What is the 5th M mode? This is the one, IVC M mode. Why IVC M mode? لأن it makes it easier for the assessment of diameter and collapsibility. يعني الآن كده مثلا أنا am seeing it, then I'm gonna follow it for like 6-7 beats and I measure it during inspiration. So I have two measurements, one during expiration and one during inspiration, so I can assess the collapsibility less than 50, more than 50, or it doesn't exist. Okay, so IVC M mode. Okay. We also have the segmentation of the heart. Segmentation. What do you mean by segmentation? We have 17 segments of the heart. Okay, so we are gonna cut the heart in different orientation, like we said before. From the apical window, we have apical 4, apical 2, apical 3. And from the short axis, we have short axis basal level, short axis mid cavity level or papillary level, short axis apical level. So what are these 17 segments? Easy by the way, لكن remember يا شباب لازم تحفظوا. It's easy هما. يعني when we come to the basal level, this one is anterior. So this one is anterolateral, this is inferolateral, this is inferior. And from here to here is the septum, because the RV is on the right side, on the left side. So this is what? This is the septum. The septum is divided into two, inferoseptum and anterior septum. Inferior septum and anterior septum. This is at what level? Basal level. How many segments do I have here? 6. Let's come to the mid. Again, I have anterior, anterolateral, inferior, inferior, and the septum is inferior septum and anterior septum. So how many segments do I have here? 6 segments. Now we come at the apex. Now in the apex, the septum is only one, the lateral wall, inferior wall, and anterior wall. So how many do I have? 4. So the total is 6 plus 6 plus 4 is 16. So we said we have 17 segmentation model. Where is the 17th segment? 17th segment is this one. Look at this one, the apical cap, the very distal part of the apex, the very distal part of the apex, which is not seen here. You see it if you go further down, 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 until you kind of obliterate any cavity and you see kind of a solid segment like this. So it's better seen in the apical window than in the short axis. This is the 17 segments. Yes? So this is the 17 segments which is adopted by all cardiac authorities everywhere. 17 segment corresponds to the different coronary artery distribution. We know that إذا أخذت أنا الانتيرير مع الانتيريو septum is what? Anterior مع anterior septum is what? Is LAD, right? هنا if I take the anterolateral مع الانفيرولاترال, this is what? Circ. If I take the inferior with the inferior septum, this is what? RCA. Yeah. So why is this segmentation important? Because if بعدين لما أجي I analyze the motion of the heart, I'm gonna analyze it according to this model. So I'm gonna tell if the contractility is intact in all segments or there is a problem. And if there is a problem, is it global, involving all the segment equally, or it's regional? بمعنى the anterior wall is hypokinetic, the lateral wall is not hypokinetic. So that means I have an LAD problem. Or it may be normal here and here and here, but the inferior wall and the inferior septum are hypokinetic, meaning I have RCA problem. Or I might just have the problem on this lateral side, meaning I have CERC problem. Or I have a mix of this and that, and I have multi-vessel, 2-vessel, 3-vessel disease and stuff like that. Okay? So these are the 17th model segmentation of the heart. 17th model segmentation of the heart. في بعض الكتب القديمة ممكن تلاقيها لسه 16 segments of the heart, excluding the apical cap. Okay. طيب. Remember that we have echo, we have invasive hemodynamics, which are cath-based hemodynamics. We also have cardiac CT, cardiac MRI, nuclear cardiology. This belongs to the field of cardiac imaging. Okay. وحتى الآن طبعا الإيكو is subspecialty لوحدها in cardiology, and cardiac CT, MRI, and nuclear cardiology is summed up in one subspecialty اسمها advanced cardiac imaging, which is 2 years program. Okay, advanced cardiac imaging. Invasive hemodynamics are kind of needed in a very exceptional situation when the echo is uncertain or ambiguous or doesn't give the answer. You might need invasive hemodynamics في بعض الأحيان. أذكركم سابقا زمان, if we go back like 15 years and stuff like that, it is invasive hemodynamics which direct the management. يعني الاورتيك ستينوسيس الايكو ما كان بيعرف اي شيء فيه. الناس اللي بيعرفوا severe AS by invasive hemodynamics, بيعرفوا الMR by Seller's criteria invasive, and Hookham invasive. لما جاء الايكو بدأ gradually to take over لحد ما الآن has taken over. بقى the need for invasive hemodynamic to decide about يعني valve diseases and Hookham constriction restriction is needed only rarely, if ever, very rarely. يعني أنا remember no more than handful of cases we need to send for invasive hemodynamics لأنه الإيكو doesn't or didn't settle the answer. Very rare. لكن الكاردياك CT MRI nuclear cardiology, like we will have a dedicated session about the role of advanced cardiac images في وقت لاحق وحنعرف بالضبط the utility and roles of these images. For echo, you have to remember that you have to obtain technical skills. It's also important to know the science of echo, and it's very important to know that echo as ultrasound in general is operator dependent. So how you do it is make or break. فممكن تكون a good technician, a good have good technical skills, you get a better image than somebody who had poor technical skills. We also have inter-observer and inter-observer variability in looking at the images. You may, أنا مثلا, I might give a different estimation than Yasin مثلا. This is called inter-observer variability. لكن الانتر-observer variability should not be wide. وجزء من الكواليتي assurance and quality assessment for any echo lab انه الانتر observer variability يكون المارجن او الجاب حقها is very narrow لانه اذا echocardiographists in the lab are giving different answers to the same image معناتها في مشكلة يا إما في الإيمج يا إما في الإيكوكارديوغرافر في مشكلة كبيرة. الانتر اوبزرفر variability yes is acknowledged and recognized and appreciated لكنها it shouldn't be wide. There is also intra-observer variability اللي هي the difference between Khirallah today and tomorrow in analyzing the image. يعني اليوم أنا might see the mitral valve and I say إنه this is severe MR. When I look at it tomorrow in another setting, I change my mind. So this is intra-observer variability. Again, it's a problem and it has to be bridged. This gap has to be bridged or has to be narrowed down. طبعا echo if compared to other images is safe. يعني مثلا السي تي فيها radiation, الام ار اي فيها claustrophobia, لكن الايكو ما فيه مشاكل. It's the only portable one. صح؟ يعني CT scanner you can take it anywhere. You cannot drive CMR scanner to the bedside. The other thing is ubiquity. Ubiquity معناته the availability. How widely available this technology is. يعني الإيكو موجود everywhere. موجود في tertiary center, primary, secondary. لكن CT MRI إلا في شوية tertiary quaternary centers. It's like technicality is also هنا تختلف. التكنيكاليتي of echo is a bit difficult compared to CT MRI. CT MRI is more algorithmized بمعنى it is software dependent. يعني انت قاعد في السي تي ولا قاعد في الام ار اي protocol is so clear. You put the scanner, you set the scanner there, things are in the workstation. لكن الإيكو no, الإيكو depends on your hands. يعني your hands have a lot to do with it. لكن في السي تي الام ار اي your hands is not that important. ولذلك الفيزيشن في السي تي والام ار اي مرات ما بيكون حتى موجود during the acquisition of the images, بيجي just to report. لكن for echo cannot be. For echo you always have to be there to assess the image and to acquire by yourself if there is any ambiguity or things not answered. طبعا in the 50s, Edler and Hertz, this is an alliance between a physician and a physicist. They started to drive from warfare technology into medical technology. They started the first use of ultrasound in the study of the heart, and they get images like this. Then came Feigenbaum, who is the father of echo, you know, and he wrote his book, the first book of 1972, the first book in echo by Harvey Feigenbaum. And basically it was about M mode and, you know, bright modes. And the first disease that was seen by the first technology of echo was precardial fusion. Then gradually things has gone forward. I want to remind you that in echo, like when we are going to discuss later together, there is always anatomical data and hemodynamic data. So we look at the structure, how it looks like, and then we have the flow of the blood, the pressures in the chamber, and all of that. These are called hemodynamic data. And we always should obtain and get the two data. Anatomical data by itself is not enough. Hemodynamic data by itself is not enough. يعني الآن if I tell you that I have a gradient across the aortic valve of 40 mean. The question is, you cannot answer this question. If I ask you, what do you think the problem is? You cannot. لأنه سؤال يفترض تسألني how the aortic valve looks like. How it looks like. If now I'm gonna answer you that it looks severely calcific, degenerative with limited opening. Then okay, this is the aortic valve morphologically, this is the gradient hemodynamically, so I have severe aortic stenosis. If my answer was the aortic valve looks so nice, opening well, no much of calcification, but I have this high gradient, then you might think that the obstruction is maybe below the valve or above the valve. So if I give you anatomical data alone, it's meaningless. Hemodynamic data alone is meaningless. So you have to have anatomical and hemodynamic together to have judgment about the problem. Okay. ولكن في الإيكو sometimes we have anatomical hemodynamic mismatch. وطبعا usually أنا أطمنكم most of the time what we get is match. بمعنى the anatomy gives an idea and the hemodynamics gives the same idea. يعني مثلا the aortic valve is calcified with restricted opening and there is high gradient. So there is anatomical hemodynamic match. Sometimes there is anatomical hemodynamic mismatch. بمعنى the aortic valve is severely calcific and degenerative with restricted opening, but the gradient is only 20. So this is mismatch. Or the other way around. The anatomy, the valve looks nicely opening, but I am getting high gradient across it. So this is mismatch. So you have to do reconciliation. There is a problem here. You have to pause and sort it out. And this, when we come to the problem, a special problem, we are going to talk about the mismatch. At echo level, we also have mismatch between the clinical and echo data. بمعنى البيشنت مثلا يجي symptomatic severe shortness of breath. You do echo, you find severe mitral stenosis. This is clinical echo match. Great, well done. So the patient is symptomatic because of severe mitral stenosis. Now, if this same patient, the echo has shown mild to moderate MS, this is called clinical echo mismatch. In this case, you have to do something. So the mismatch is like the echo is showing severe abnormality, but the patient is asymptomatic, or the patient is symptomatic, but the echo is showing mild to moderate abnormality. So these are mismatches between the echo and clinical data, and there is a special way of sorting them out, okay? When we come to study each one separately. طبعا I also want to remind you that in medicine, physicist has played a major role, and we have Doppler, we have Daniel Bernoulli, and we have all of that. Now, as far as echo is concerned, I want you to remember 4 things. Piezoelectric effect, right from now, because I'm not gonna repeat it again. This is piezoelectric effect, Doppler effect, Bernoulli equation, and continuity equation. Okay, these are the 4 physical principles we use in echo, and we use so frequently, as in like you are gonna get so exhausted with this. The piezoelectric, you know the transducer we are holding? The transducer houses piezoelectric crystal. which is basically how electric current changes the crystal to oscillate and produce ultrasound wave, and how the retaining echoes transform or deform the crystals to generate electricity. So the piezoelectric effect goes bidirectional. Electricity into ultrasound and ultrasound into electrical effect. So it goes this way, yeah? So this is how we generate ultrasound and how we generate the image. We have the Doppler effect, and we talk about Doppler effect and its application in echo is gonna be color Doppler, BW, CW, tissue Doppler. We have Bernoulli equation, which gives us idea about the different in gradient, the difference in pressure gradient between two nearby chamber opening into each other. How can I calculate the difference in pressure? By the use of Bernoulli equation. The continuity equation is also used in assessing the flow of blood in the heart and getting the area of the orifices by the general principle that what comes in must go out. So the volume below aortic valve is equal to the volume above the aortic valve. So by equalizing these two volumes and using this equation, I can get the area of the aortic valve or the area of the mitral valve or the area of a hole or all of that. So these are the major two equations we use in hemodynamics of echo: Bernoulli equation and continuity equation. And of course, the piezoelectric is the one driving the transducer, and the Doppler effect is what we use to get all of that. طبعا echo has progressed from a small M mode kind of images, bright mode, to 2D, 3D, and now we have the 3D and we have images like that. And we also have the strain, yeah, which is also important. And if we have time in later sessions or in chamber quantification, we might touch on the utility of strain images. And also the echo has changed in size. It becomes portable. Now we have mobile-based echoes. طبعا the laptop or the tablets is now everywhere. لكن حتى الآن بقى في the mobile. So there is a software you download in the mobile and you just have the probe which you connect. حتى في probes بتشتغل بلوتوث مع الموبايل. So you can see the images in your mobile. Okay. We have TEE and this is the TEE probe. لكن remember, a TEE though it is fascinating للfellows, لكن الكلينيكال utility حقته limited. يعني echo transthoracic echo is more versatile, okay, than TEE. TEE is usually done for particular reasons. After you do transthoracic echo, you want to refine the diagnosis. You want to go for a specific kind of question you need to answer, stuff like that. لأنه it is semi-invasive procedure, so you don't do it as frequent as you do transthoracic echo. There is always a particular indication for using TAE. And this is the stress echo. طيب ستريس ايكو طبعا غالبا الناس بتكون سمعت الدوبيتامين ستريس ايكو دوبيتامين يس لكن يعني الدوبيتامين is pharmacological stress. Sometimes you need physical stress بالذات when you are evaluating for valve disease, mitral stenosis, severe, not severe. So how can I do it? طبعا of course you can run a patient on a treadmill and you get the echo. لكن the problem with that is what? إنه once you gain the peak of the heart rate during peak exercise and the time you want to shift the patient back into bed and put him on the left lateral position, put your probe, the heart rate is going to decelerate. What you have gained in the treadmill is going to be lost. That's why it's better to have bike ergometer, which is this one, bike ergometer. So the patient is exercising while you are acquiring the image. So this is the physical echo lab in which we use bicycle ergometer. So the patient is, طبعا the workload is not as much as generated by the treadmill, لكن it's still reasonably okay. You can achieve what you like to have with this ergometer. Like, what is this here? This is the use of contrast. Contrast. You look at this here, before and after contrast. This is called ultrasound enhancing agent, UEA, ultrasound enhancing agent, like Sonoview, Optizone, Definity. These are all ultrasound enhancing agent. We do them to enhance the LV border or the LV endocardial border. That's why sometimes they call them LVO, left ventricular opacification agent. So they opacify the LV cavity and they appear, or they show the wall so nicely like this, so you can track the wall so nicely. And you can get an accurate assessment of the regional wall motion abnormality, accurate assessment of the ejection fraction, and all of that. They can also be used, like, look at this LV here. And do you see the apex? No, definitely I can't see the apex. I might hypothesize there is a thrombus, there is no thrombus, but honestly speaking, you can draw a firm conclusion out of this. But when you give contrast, now you see everything clear. You see these are just trabeculation, there is no thrombus, and I know exactly how the apex looks like. In another patient, I see a thrombus, which wasn't seen by plain echo. In another patient, I was seeing some like this. This is foreshortening or this is stout muscle? I don't know, but when we give the contrast, it shows non-compaction. So deep recesses and trabeculation there. Also, look at this LV here. We don't see anything in particular, but when we give the contrast, we start to see that this is a very muscular LV, and this is pear-shaped contrast morphology, which is apical hookum. And now here, we also give contrast, and we see that there is mid-cavity obstruction and kind of apical aneurysm here, pulsion aneurysm at the apex. What's the meaning of that? And I can give contrast to disclose apical pathology that are not clear on plain echo. So these are the two utilities of contrast. One is for better delineation of the endocardial border for the assessment of LV function. Two, to disclose apical pathologies. You are suspecting a thrombus, you are suspecting non-compaction, you are suspecting apical hookum, not well seen by plain echo, you give contrast. Okay. Remember POCUS, now there is courses for POCUS, by the way, point of care ultrasound, not only in echo, but everywhere, not only in echo. So POCUS is the point of care ultrasound. والآن زي ما وريتكم بقت a pocket health. You can mount an entire software of ultrasound echo in your mobile. So it is clearly POCUS. You can do it wherever. It replaces your conventional stethoscope, so you can just hold it anywhere and you move around and you do for patients, just like the obstetrician are doing, the rheumatologists are doing, the ER physician are doing it, the intensivists are doing it for lines, insertion, and stuff like that. So it becomes commonplace, by the way, POCUS. Now do you hear about interventional echo? Now بقى في انت مثلا الان لما تعمل echocardiography fellowship program، في program بعدها which is 1-year program. It's about structural heart disease intervention echo, which is interventional echo. Okay, لأنه they found that بعد الecho you need some kind of sub-specialization for a special procedure. Now for mitral ballooning, for mitral stenosis, for TEER, TEER stands for what? Sometimes they call it TEER, sometimes they call it PEER, which stands for transcutaneous edge-to-edge repair, or percutaneous edge-to-edge repair, which is mitral clip and tricuspid clip for MR and TR respectively, okay? We also have valve in valve. If you have bioprosthetic valve, which is degenerative, you can put a new valve or implant a new valve and you mount it on the frame of the all valve percutaneously. This is called valve in valve. We have TAVI, which is transcutaneous aortic valve implantation. We have paravalvular leak occluder device. We have defect occluder device like ASD and VSD. Pericardiocentesis can be done by echo, yes. LA occluder device and AF ablation. So from these, which one needs guidance? طبعا for all we have to do echo. لكن do you need guidance? Do you need guidance بمعنى you have to be with the interventionist while doing the procedure? Yes. In TEER, in valve, in paravalvular occluder device, in defect occluder device, in LA occluder device. You don't have to be in TAVI. Pericardiocentesis is better done by echo, lakin not necessarily. You can do it like by fluoro guidance, which is not safe, by the way. Echo is going to make it safer. ولذلك the standard still is pericardiocentesis. Though it's not essential, ولكن it makes it safer. The same applies to mitral ballooning for mitral stenosis. Do we do it TE guided? Not necessarily. في ناس كثيرين في السودان بخبرات واسعة they can do it fluoro guided. ولكن if they do it TE guided, it's going to be safer. Okay? The same applies to AF ablation. So you see now how frequent the echocardiographer is now present in cath lab? A lot. This is interventional echo. If we look at it here, these are schematics or quick demonstrating videos of the mitral clip. You see the mitral clip, they open it, they position it, they assess the perpendicularity, they assess where the jet is, and they deploy it. So this procedure isn't easy. It takes on average two to 3 hours. So you define the fossa valleys, you define where you go by T, of course, and you direct the septal puncture, and then you direct the clip system into the right position with the right perpendicularity, and you make sure that the deployment of the clip is right, okay, and no detachment, and then you assess the MR after, you assess the gradient after. So this is TAVI, and TAVI usually is done fluoro guided. They don't need us in echo. Lakin valve in valve, once you have bioprosthesis, they need you, especially for mitral valve, because they have to pierce the septum, but they also want to see exactly where they position the valve and stuff like that. So TEE might be helpful here. For paravalvular leak, definitely they need TE guidance. They can't do without you. So you are going to tell them exactly like in here, this is the catheter guided towards the hole and where they have to go and how they put their plug, and if the plug is enough seal, if there is residual leak, is it encroaching upon the valve disc, or all of that, that's done by TE guidance. Of course, pericardiocentesis is safer and faster by echo. You can do it like we said by fluoro guided, or حتى sometime by blind subcostal puncture, لكن it's not going to be safe. It's going to be safer and faster by echo guided. بالنسبة للmitral ballooning, again, mitral ballooning, it's better to be done by TE guided لأنه we show them the septal puncture and the inflation, and then how the valve is split in the commissure, if there is MR, new appearing MR, how the gradients drop after, how the area changes before and after ballooning. So the T guidance is also important here. Now, echo for emergency is so important. بالذات لما يكون مثلا عندك patient زي ده. What do you think this patient has? This one here. Once you see this one,
Dissection, aortic dissection.
exactly. So this is dissection type A. So these are the cases in which you should shout out loud for help. This is a dissection flap and it's interfering with the closure of the aortic valve. So there was actually severe AR as well. Look at this one here. Again, this is dissection flap. It's dilating the aortic root and is splitting the two cusp apart. So there was severe AR. If you look at the aortic valve, also is pathological and there is prolapse here. Now look at this last case. Ascending aorta, no flap, but look at the descending aorta. There is flap. So don't forget to look down there. This is type B dissection. Type B dissection. Okay, so this is type A, type A, type B. Now look at these cases also. Again, emergency echo for a patient with papillary muscle rupture. You see the papillary muscle here is ruptured and there is severe MR. This is also VSR. VSR is ventricular septal rupture. So there is ventricular septal rupture here. And you see why this is not VSD. Because if it is just VSD, I wouldn't expect to see a hypokinetic segment. Look at the segment here. It's not moving. And there is a hole. So this is VSR. The clinical context is also important. But looking at it this way, لأنه لو كانت congenital, the septum is going to be contracting well. And there is a hole into it. لكن يكون akinetic with a hole, this is VSR. And this is apical thrombus relating to severe cardiomyopathy and severe LV dysfunction. Okay, I'm gonna skip these things. Back to this one, you see this is fat, okay? These are all fat. See how thick this fat is? It looks like having a tumor around the heart, stuff like that. This is fat. Type, look at this MR. This is MR for this patient. This is MR for the same patient after something done to this patient. So can you give me your guesses about what has been done to this patient to shift this MR from this magnitude to this magnitude? Can you? Just a moment. Shabab, did you say anything?
By
Possible underwent mitral clips.
Mitral clip, yes, possible. Like there was no mitral clip. The mitral valve
device
as
will
it is.
drop atrial.
Sorry?
Any device interatrial septum
No,
batch.
no. طبعا you might say إنه it is functional MR. The LV was weak and then improves. لكن if you look here, the LV function is as it is now. ما في change in LV function before and after. لكن we have done a procedure. What is this procedure? طيب.
Septal puncture.
Septal
puncture. Atrial septal puncture. Interatrial septal puncture.
Interatrial septal puncture might ease the obstruction and the gradient of MS, but the MR don't think is going to change. طيب, the procedure was done for aortic valve and it is TAVI. So here, before TAVI, and this is after TAVI. So does that explain this change?
No.
وهنا our evaluation of this mitral regurg is moderately severe. Let's say moderate to severe. Now this is what trivial MR. So it has changed a lot. And it has been found that at least 44% of patients of more than moderate MR decreased to less than moderate MR after TAVI. Yes.
Surprise.
لكن هي لو حسبتيها physiologically it makes sense.
Yeah, we have a
Yes,
questions
كده.
like if the MR will decrease after the valve replace
Yes,
aortic valve. So
exactly.
is it
Exactly.
like this magic?
Yeah. يعني مثلا الآن لو عندنا severe obstruction هنا،
مم.
تمام، the blood is gonna be going this direction.
True.
لأنه
Yes.
afterload is very high. So it's venting the afterload through the mitral valve. If you open it here, you ease the afterload, you are gonna ease the problem on the mitral valve. Yes. فلذلك التشينجز بتحصل in 44%. طيب what is this here? This is suprasternal window. What are we seeing?
PE.
Huh?
It looks PE ولا هنا.
Here that suprasternal window. In suprasternal
aortic.
window,
Aortic
yes,
أيوه.
you see the descending aorta. So this is here ascending, here is the carotid subclavian, and this is the descending
Yeah.
aorta.
Yes, yes. Coordination
what?
of aorta.
Or here, what you see here,
Yeah.
mobile atheroma. This is mobile atheroma.
Thrombus, yes.
Yeah, this is important, by the way. Mobile atheroma is important. لأنه مرات if they are intervening with this patient بالذات لو كان الأكسس femoral, they are gonna come this way. Okay, and look at the carotid artery. So they can take this one and put it here, major stroke. Yeah?
Stroke, yeah.
فبالتالي مهم جدا أنك you report atheroma, and you know the grades of atheroma are 5. If it's mobile, this is grade 5, which is the nastiest grade. We're gonna skip these. Now for the masses, we are gonna have a separate session on masses, but let me just pick your brains about this. What do you think this mass is?
Myxoma, atrial myxoma.
Very good, very good. And what is this mass?
Again, could be myxoma.
Could be myxoma, لكنها it's inside the muscle in the posterior wall. This is fibroma, which is arrhythmogenic.
Fibroma, okay.
Yeah.
Okay.
And what is this here? This is malignant. So what is it? The most common primary malignancy of the heart is what? The most common.
melanoma,
Yeah. Angiosarcoma.
Angiosarcoma.
Yeah. The most common primary. طبعا the most common malignancy of the heart is METS. Yeah. لكن primary malignancy of the heart is angiosarcoma. And usually it is on the right side, you know. It involves the right atrium and the right ventricle associated with precardial effusion and stuff like that, yeah. Very poor prognosis. طيب, look at this patient here. I have a small rim of precardial effusion, and here is the short axis. Okay. ده هنا مشكلة الإيكو إنه it has narrow field of view, لكن sometimes you are gonna see extra cardiac structure. And it's important to look at it. Now, this is the LV, which is fine. This is the RV, which is fine. There is precardial effusion here, but there is this thing here. What is this? This is polycystic kidney or polycystic liver. This is most likely polycystic liver. Okay. So once the liver is large and polycystic, by the way, this patient is having end-stage renal disease on dialysis due to polycystic kidney, but we also see the polycystic liver in echo, because the liver, we can see it in echo. Sometimes a large kidney, which is polycystic, you can also see it here, yeah? Remember, إنه الecho, sometimes, though it has narrow field of view, you can see extra cardiac structure. So you have to familiarize yourself with some stuff like this. This is a 55-year-old lady. She had metallic mitral valve 3 years ago, presented with chest pain, shortness of breath, ST depression in precordial lead. Her troponin is 0.2. So given this scenario, chest pain, ECG changes, and elevated troponin, this is acute coronary syndrome. Which type? Which phenotype? non-STEMI. Non-STEMI, right? Acute sclerosis syndrome has 3 phenotypes. Unstable angina, STEMI and non-STEMI. So no ST segment elevation, but there is leaking troponin. This is non-STEMI. So this is non-STEMI. We have done echo for this lady, and this is the echo. So what's the problem in here?
Apical dilatation.
Exactly. Yes. So if you look at the base of the heart is contracting, mid to downward to the apex is not. And here at the apex is severely hypokinetic. So what's your response here? What's your best course of action you suggest?
Do the coronary angio.
Exactly. We have done angiogram for this lady and it's normal.
Broken heart syndrome.
Exactly. This was a case of broken heart syndrome, which is Takotsubo. This is how it looks like. And we are going to have a special
Session.
session about cardiomyopathies and all of that. Okay. So
Yeah.
I'm going to skip these things because I think we are going to do them in the special lecture. But I want you to remember, this one is what? Modified Simpson way of evaluation of the ejection fraction. We are gonna discuss it technically how we do it when we evaluate for ejection fraction. And when we come to the regurgitation evaluation, I want you to remember that the jet has 3 components. This is very important. The jet has 3 components. Look at this jet of AR. It has a hemicircle here called flow convergence, and it has a neck here called vena contracta, and it has the jet. So there are 3 components: flow convergence, vena contracta, and the jet proper. So how we evaluate the severity of regurgitation, whether it's AR, MR, TR, PR, it's the same. We go for these 3 components. There are metrics that relates to the flow convergence. This is called PISA. Okay. There are metrics that relates to the vena contracta. There are metrics that relates to the jet. طبعا لو الجيت مثلا هنا simply انت ممكن تقول لي the wider the jet the more severe. Yes, right. The wider the jet the more severe. ولذلك في metrics relates to the jet area. كل ما كان wide كل ما كان. ولكن الجيت is towards where? It's toward the receiving chamber. صح؟ الجيت goes to the receiving chamber. So it is now no longer represent the severity, but represent the severity along with the influence of the receiving chamber. يعني الشامبر دي إذا كانت dilated or not dilated, البريشر فيها high or not high is gonna influence this part. ولذلك the jet area part is not accurate in the evaluation. What is accurate is the initial half of the jet, which is the vena contracta and the flow convergence before it gets contaminated with the receiving chamber. ولذلك when we discuss the regurgitation, we are gonna focus on the vena contracta and the flow convergence. مع إنه we are gonna tell how the jet area is meaningful sometimes, but remember the accuracy of the jet evaluation as it goes, as it dives into the receiving chamber is lost. The accuracy relates to the original part of the jet, which is the flow convergence and this one. حتى هنا الآن. This is the flow convergence. This is MR. This is the flow convergence. This is the vena contract, and this is the jet. This jet, the area of this jet is affected by whether or not the jet is central or eccentric, the pressure in the LA, the size of the LA. لكن this part is not affected by these factors. ولذلك it's important you go there and analyze severity based on the origin of the jet. Okay? طيب, we're gonna skip all these things, AR and MS. So next, what we are gonna do is, we're gonna have a special session for these two together, LV quantification and RV quantification. MR and MS is going to be grouped in one session, and problem might group it with AS and AR. And if the session is like 1.5 hours, I think we can group them together. TS, TR, PS, and PS can be just covered in one shot. Precardial disease need a special session. Cardiac masses is not common. Is not difficult. Less than one session. I might include it with this one, with contrast echo. So contrast echo and cardiac masses can be in one. Congenital heart disease, because it's long, it's going to be in one complete session. The same applies to this one. So we have one here, one, and one. So these are 1, 2, 3, 4, 5, 6, 7. 7 sessions. Okay. 7 sessions. طبعا I'm optimistic إنه we meet twice weekly, لأنه if we meet twice weekly, 7 session is gonna finish in 3 weeks. لكن if not, it's gonna be 7 weeks. Okay. لكن I have already arranged for all of these things this way. Might not be the same arrangement. We might take مثلا contrast echoes كده. ممكن يكون في بعض changes. لكن I'm gonna start with the basics first as much as possible. Okay. المحاضرة القادمة حتكون يعني لما نقول LV quantification, RV quantification is gonna expectedly cover everything from basics to advanced. So F1, F2, F3 كلهم حيستفيدوا منها لأنها حتكون comprehensive for everything that relates to echo in this particular condition. Okay. So طيب يا شباب، عندكم أي أسئلة؟
شكرا جزيلا دكتور حاتم. بس كنا